This lecture was planned some time back. Because of that, the date is bit different, right? Okay. So we'll go forward for the first slide, please. Go to the first slide, please. Yeah. So we'll start with what is a convulsion. So a convulsion is a medical condition where body muscles contract and relax rapidly and repeatedly, result in an uncontrolled shaking of the body. So convulsion does not mean that is a seizure. So convulsion is only a condition where body muscles contract and relax, uh, resulting in uncontrolled activity, shaking. So that is a convulsion. So I wanted you to highlight the difference between convulsion and a seizure before going into febrile seizures. Okay. Shall we go to next slide, please? Yeah. So seizure is may or may not be a convulsion, but that is due to as a result of synchronous abnormal excessive neuronal activity in the brain. It may or may not give rise to a convulsion. Okay, the next slide, please. So during a seizure, massive number of brain cells are activated abnormally at the same time. So it's like, you know, a storm of electrical activity in the brain. Yeah, next slide, please. Yeah. So nature of the seizure depend on several factors. So it depends on obviously the person's age, the sleep-wake cycle. So that's why there are different seizures in sleep, which occurs only during the sleep. And most of the convulsions, in fact, occurs during the transient period in between sleep and wakefulness. So other factors, dependent factors are prior injuries to the brain, obviously some genetic factors, medications, some certain medications and many others. Okay, next slide, please. Yeah. So the classification of the seizure goes back to history a long way. So earlier it was classified as grand mal and petit mal seizures. So over last 35 to 40 years, this classification changed very rapidly. Nowadays, we classify seizures as whether they are partial seizures or whether the person was, if the patient is, or whether it is a generalized seizure. So go for next slide, please. Next slide, please. Yeah. So we'll go for the new basic classification, which is easy to recognize and easy to remember. So the classification, the factors considered for the new classification of seizures are where the seizures begin in the brain and level of awareness during a seizure and some other features of the seizure. Okay, the next slide, please. Yeah. So depending on that, the basic classification, classify it into whether it's a focal onset, a generalized onset, or an unknown onset. So the focal onset type, it is subclassified whether the awareness is impaired or not. Then again, whether it is motor or non-motor onset. The generalized onset seizures are also classified depending on motor or non-motor. So if it's unknown onset seizure, that is also classified whether it is motor or non-motor, and there is some unclassified group as well in the unknown onset category. Right. Next slide, please. Yeah. So how to approach a child with the convulsion is the first half of the lecture. So the convulsing child, our objectives are to understand the structured approach to the child with convulsive status and to understand the protocol for the treatment and to introduce the drugs used. So I'm describing these events step by step. Okay. Next slide, please. Right. So a convulsing child. So one of the commonest cause for convulsions it can be onset can be induced by a fever. So that's why we call one of the examples are febrile seizures, or it could be a child with an epilepsy uh, developing a seizure with fever. So that is fever-induced convulsion. And other causes are cerebral hypoxia, central nervous system infections, or some metabolic abnormalities, some probably epilepsy or withdrawal of the anticonvulsants. Right. So next slide, please. So in the convulsed child, the assessment goes to as usual. So we have to do the basic assessment of the convulsing child before starting on the treatment. So we have to assess the airway, breathing, and the circulation. So airway assessment, I don't have to describe further. So and you have to make sure that the airway is open and it's not obstructed by any secretions or any foreign bodies. And then go for circulatory assessment. So if there's a bradycardia, it might indicate raised ICP, or if the child's blood pressure is very high, so it could be hypertensive encephalopathy giving rise to a seizure. So the next slide. So assessment goes to disability. So this to distinguish it from uh, posturing, the dystonic reactions, or it could be a pseudo. But you don't ever forget the glucose. All the convulsing child, you have to do blood glucose level because hypoglycemia can cause seizures or it can cause neuroglycemia if you don't correct it promptly. Next slide, please. So initial resuscitation includes open and maintain the airway, make sure high flow oxygen is given, and you might have to give more ventilatory support if necessary, and fluid resuscitation if needed, and if do give glucose if the blood sugar level is low, and then go for the management of convulsion. If you go for the algorithm, the next slide, please. So the algorithm for managing the seizure is, so we have to all depends on your vascular access, right? So whatever the your seizure management, if there is a vascular access, you are lucky. If the vascular access, you can easily go for intravenous route for the management. So initial management is you can go for intravenous midazolam or diazepam or lorazepam, but midazolam or lorazepam are better than diazepam because T half of the those drugs are lesser than diazepam. Okay, you go for that. And if it doesn't resolve after 5 minutes, you have to go for the repeat dose. And even if it doesn't resolve within that time, you have to go for another drugs like phenytoin or phenobarb. Uh, so preemptively, you have to make sure all these options are available for the management of the child because we don't know where you are ending up with. But if you are unfortunate, you don't have IV access, still you can go for midazolam, buccal or intranasal route, or else you can although this is not available here, you can give the IV diazepam or midazolam per rectal route by using NG tube. The dose is a bit different. Usually we give zero point 0.3 milligram per kg if it's intravenous. But if you don't have IV access, you can use the rectal tube and give the IV diazepam from the rectal using the NG tube, not as an injection. But the dose is 0.5 milligram per kg in that case. So whatever after that, if it doesn't resolve, you have to go for second dose. And if it doesn't resolve, and if you are so unfortunate you don't have IV access yet, you might have to go for deep IM paraldehyde or PR paraldehyde. You can go for that. And if you get the access in between, then you can shift to the intravenous access site management. That means you can go for phenytoin or phenobarbital after 10 minutes of continuous seizure. So if you are very unlucky in the managing this child, he doesn't stop the convulsion even after dose management, you'll have to go for induction of anesthesia by thiopentone or propofol. Okay, so we go for the next slide. Right. That also indicates same thing. Okay. So then, okay, I will skip the next slide. Okay. Yeah. Go for the next slide, please. Yeah. Uh, so we generally do not give more than 2 doses of benzodiazepine uh, because you might go into respiratory arrest if you give more doses of benzodiazepines. Anyway, if you are managing a child with status, must be aware of this problem, and you have to be prepared to manage the respiratory arrest as well. Okay, so after that, as I earlier mentioned, the next slide, please. So reassess airway breathing and circulation. Next slide, please. And then you might have to take senior advice. Is it definitely an epileptic seizure or not? Right? So you have to rethink about the diagnosis. So you must be equipped with your blood glucose level by now. So if it is low, you have to obviously correct it, and you have to go for the next step as I have mentioned earlier. Right, the next two steps I have mentioned earlier. So, so if the child is not settling with this, you can go for consider trial of pyridoxine. The child is less than 3 years old. Go for next slide, please. Yeah, and then you can consider. You have to consider next slide, please. Next slide, please. Yeah. Then you have to consider all the children with status epilepticus. We have to consider treatment for increased intracranial pressure after you have controlled the seizure. So, okay, go for the next slide. Yeah. So, convulsing child. So, the complications are, as I have mentioned, you can develop cerebral edema. In addition, other complications are pulmonary edema, hypothermia, cardiac arrhythmias, hemoglobinuria, hypertension, and DIC. Right. So, go for the next slide. Keep it. Right. Skip that slide. Okay. So, we have to monitor if the child is having status, we have to monitor airway breathing circulation and monitor for further seizure activity. And meanwhile, you have to work out for underlying cause. Right. So if the child is convulsing with irritability, fever, and rash, what would it be? You have to think about meningitis. Right. So if the seizure is rapid onset, you have to think about either cerebrovascular accident or poisoning. So if the history is vague and suspicious of bruising, you have to think about non-accidental injury. So if the child is having very high blood pressure, you have to think about hypertensive encephalopathy. Those are few examples, right? Right. Then I would go for the discussion about the epilepsy, right? I think the topic was a bit altered now that we are going to discuss rather than only discussing about cerebral seizures. I thought of discussing about epilepsy because it would be more important for you rather than discussing about cerebral seizures. Okay. So what is epilepsy? So epilepsy is a group of disorders. So by definition, epilepsy is two or more unprovoked seizures within 24 hours apart. So it doesn't mean that you have to wait for two unprovoked seizures to diagnose epilepsy. It's one unprovoked seizure, and the probability of seizure is very high. So then you can think about starting anticonvulsants for even for one unprovoked seizure if you are confident that the seizure is an unprovoked one and it's definitely a seizure. Right. So, what is childhood epilepsy? So that is the pediatric topic. Proper. Then that's markedly a heterogeneous group of disorders with wide range of clinical semiology, with vast range of EEG patterns. And to further complicate the matter, there are different types of syndromes involved, with multiple etiologies, and obviously different outcomes. So epilepsy is an umbrella term like there are lots of diagnoses inside it. It's not a one diagnosis. It could be either of those. So, uh, depending on the etiology, depending on the syndrome, there are a lot of challenges as a pediatrician to diagnose and treat this child. So, first you have to identify specific epilepsy syndrome, if at all. So that will give you the prognosis, seizure control, seizure free time, and obviously, most importantly, the cognitive outcome of the child. So depending on the etiological diagnosis, you can go for the medical management or whether you want to go for surgical intervention, and most importantly, genetic counseling if needed. The choice of medication also depends on your syndrome. As an example, you can have targeted treatment in Dravet syndrome, Best syndrome, and TS complex. Right? Okay. The next slide, please. So, according to the NICE guideline, epilepsy onset less than 18 years considered to have identified etiology about 60% of the cases. So, unlike in adult medicine, we have identifiable etiology for most cases. That is why pediatric epilepsy is completely a different subject from the adult epilepsy. So it has need to be evaluated and must be evaluated by a pediatrician or a pediatric neurologist, not by adult neurologist. Okay. So assessments under consideration are pediatric cardiology, sometimes very important because it can be the root cause, and clinical genetics, metabolic evaluations. Rarely you might need multidisciplinary epilepsy surgical teams help as well. Right. So what are the investigations available needed for the child with an epilepsy? ECG is an utmost importance for all the children with epilepsy. Right? Before embarking on EEG, you have to go for ECG. And obviously, EEG to diagnose and to classify basically. And you might go for sleep deprived or medication induced EEG. Our country also we do video telemetry EEG and ambulatory EEG. Invasive EEG we don't do here in Sri Lanka, but that's a good option. You can go target the site and put the electrodes and get the invasive EEG. And of course, brain imaging, preferably MRI. So sometimes CT might be helpful. And you can go for functional neuroimaging, magnetoencephalography. Genetic investigation depends on the syndrome diagnosis and metabolic evaluations where needed. Right. So ECG, what is the importance of ECG in terms of epilepsy? You might wonder whether I'm talking about ECG rather than EEG. But yes, so the cardiac, go for the next slide. Cardiac abnormality, go to the next slide, please. A cardiac abnormality would be the underlying cause. Or it could be the result of your convulsion. So ECG is to exclude or identify the cause for epilepsy. Next slide, please. Hello, how shall I? Yeah. So, so it could be cardiac arrhythmia, giving rise to your seizure, or long QT syndrome. If you develop arrhythmia, it can cause cerebral hypoxia, and it can give rise to a hypoxic seizure. So it may resemble tonic, atonic, or brief tonic-clonic epileptic seizure. So ECG is very important and must be done for all the children with epilepsy before embarking on your diagnosis and before starting treatment. Right. So then most common investigations we do for epilepsy and almost the child with epilepsy are EEG. So EEG is done not to diagnose, not to decide on your anticonvulsants. The diagnosis is a clinical diagnosis. Epilepsy is a clinical diagnosis. So why do you do EEG? To classify your epilepsy. So decision to start anticonvulsants is dependent on the history, not dependent on the EEG. So EEG has a lot of limitations. It has fairly low sensitivity and low specificity. If you do EEGs in normal children, normal population of children, you might get some EEG abnormalities, but you don't start anticonvulsants. So if you do EEG on a child with definite epilepsy, you might get a normal EEG. It doesn't mean that you don't have to start anticonvulsants. You have to. So that means it has low sensitivity and low specificity as well. And it has significant false positivity as well. And obviously, there are lots of reporting errors as well. So EEG can take you down without any reason. So don't be misled by the EEG. The diagnosis is a clinical one, but EEG is a supportive investigation, which is important for you to classify your diagnosis further. And EEG should never be done to confirm or exclude the epilepsy. But there are some exceptions to the rule for some specific epilepsy types like childhood absence or infantile spasms, West syndromes comes into the picture. Right. So what is EEG? EEG records electrical activities in the pyramidal cells of the cerebral cortex, summation of synchronous excitatory and inhibitory postsynaptic potential of the particular pyramidal cells, and is analyzed. The standard EEG is done on a awake child during integral period. It is not very successful, but very important EEG is the child with uh, half sleep stage or sleep deprived stage. You can do specific EEGs for specific diagnosis. So, as an example, if you in childhood absence epilepsy, you ask the child to hyperventilate, and then you do the EEG where you get the three spikes per wave pattern like in EEG. So the other way of activation is you can do intermittent photic stimulation to diagnose photosensitive. EEG for specific syndromic diagnosis. So what is it? So you get, unfortunately, I have deleted the EEG photos from the slides because the slideshow was too heavy to share. Right? Okay. Anyway, so you all know that infantile spasms you get a specific pattern, which is called hypsarrhythmia, and I think you all are familiar with hypsarrhythmia EEGs, and you get generalized spikes or poly spikes and wave activity idiopathic epilepsy, and you get temporal spikes in benign Rolandic epilepsy, which is the commonest diagnosis of pediatric age group. Fortunately, we have one side of hypsarrhythmia. The next slide, please. Next slide, please. Yeah, those are sides of hypsarrhythmia, right? For children with the infantile spasms. Right. So go for the next slide. So sleep deprived medication induced EEG is the most important way of assessing being an EEG. Sleep deprivation or melatonin or can, oral hydrate used to induce the sleep. The transition between wakefulness and the sleep is the most important time to catch the EEG wave patterns in a child with epilepsy. Right. So ambulatory and video telemetric EEG. So that is a new technology to diagnose, see the child activity, and then do the see the EEG pattern at the same time. So it's very easy to interpret that in that instance. The child in natural environment more likely to have an event, and it depends on the parental support as well anyway. Right. So invasive EEGs are not usually done in our country. Next slide, please. The electrodes are placed directly on the cortex and it's called electrophotography as well. So we skip that. It's not very much done in our country. The next slide, please. We go for CT. So CT can be done because that's been not very accurate all the time, but it's cheap. It's available in most of our institutions in Sri Lanka. And it's good for acute situations like trauma. And it's good to identify cerebral hemorrhages, so calcifications. Uh, but most of the time, most important investigation is structural abnormalities MRI. So MRI is magnetic resonance images based on movements of protons in water molecules. You identify a potentially surgically resectable tumor. So it can be focal cortical dysplasia, TNET, or slow growing tumor, can give back seizure activity. For neurodegenerative disorder, rarely. It's an example, mitochondrial cytopathy. So, what is the indication for MRI? If your seizure is a focal onset, you must go for neuroimaging. And epilepsy onset less than 2 years of age. Next slide, please. And then focal neurological findings. And when you do EEG, if you chose focal features, you will go for MRI, neuroimaging. And sometimes if the seizure is drug resistant, you might think about doing brain imaging with MRI. So, what is the phase for functional neuroimaging in a child with epilepsy? For example, you can do PET scan, positron emission tomography, or single photon emission computerized tomography, or functional magnetic resonance imaging. So, what is PET? So, next slide, please. PET is used increased glucose utilization due to NAS metabolism. So you can identify the particular site where the seizure is generated, the focal site where the abnormal neuronal discharge occurs by doing a PET. Right, I'm not going to go for details, those are radiological of radiological interest rather than pediatrics. Right. So, what is single emission computerized tomography? Technician 9 is used there. Required ictal and interictal imaging to diagnose it. So, lower irradiation dose than your PET. Next slide, please. And that's what I just mentioned. So, okay. So, next slide, please. So, a little bit about the functional MRI. Functional MRI is important, especially in the newborns, cerebral hypoxia, and then some particular types of epilepsy, where you can detect venous oxyhemoglobin and deoxyhemoglobin difference and map the areas of the brain involved in specific function. This marvelously shows hypoxic ischemic encephalopathy related brain injury. Right. So, there you can go for magnetoencephalography. So, accurate localization is possible. Right. So, I'm not going to go into details of those. Where you go for genetic investigation. So, pediatrics is mostly geared towards diagnosis of genetic diagnosis, genetic etiology. To go for etiology and give the prognosis to the family and give the family counsel. You need this genetic investigations. For example, depending on the genetic diagnosis, you can do specific management as well as we mentioned here. Right. So, what are the genetic investigations we can do? So, we can do array comparative genomic hybridization for CGH or single nucleotide polymorphism, microarrays to next generation sequence, or else genome sequencing, or single gene testing if you are targeted, if you know what it is. For example, Dravet syndrome, we know it is particular gene is back, so we can go for that if you're highly suspicious, depending on the clinical diagnosis. right? If you suspect Rett syndrome by your EEG or the clinical diagnosis, you can go for the particular gene localization. And tuberous sclerosis complex, TSC1 gene or 2 gene, you can map it and see what's there. Glucose transport defects you can diagnose, right? So, if you have a clue for the genetic syndrome, you have to go for those genetic investigations. Severe epilepsy in less than 2 years of age, you don't get very resistant to your treatment. And if there are comorbidities, development delay or regression, or learning disability, autism, associated movement disorder, or if the child is having dysmorphic features, you might have to go for think about genetic syndrome rather than just an epilepsy. Right. So single gene testing is needed to be targeted to do this genetic investigation if you want to diagnose it. There is a obvious limitation. There's a big challenge to pediatric genetist and pediatric neurologist when we go for genetic diagnosis. Right. And then some genetic mutations may be different in epilepsy syndrome. And some genetic conditions cannot be excluded. So those are the limitations in doing genetic investigation. So a little bit of metabolic investigation. So inborn errors of metabolism can give rise to epileptic syndrome. So accumulation of metabolites by products resulting in excitation or inhibition of the neurons can give rise to epilepsy. Right. So the next slide is a typical pediatric thinking pattern about clues to a neuroimaging syndrome, neurometabolic syndrome in a child with resistant epilepsy. So we obviously go for the family history of similar illness, and neonatal death in the family, consanguinity, developmental delay or regression, as earlier mentioned, movement disorder, physical abnormalities like microcephaly, macrocephaly dysmorphism, organomegaly, cataracts, post-factorial pigmentosa, and progressive encephalopathy, unusually body odors, myoclonic chronic seizures and epileptic spasms, unusual EEG patterns like hypsarrhythmia, burst suppression, or high amplitude theta waves with superimposed polyspasm waves, in the MRI, the agreement abnormalities. Those are clues for thinking about neurometabolic syndrome. Right. I think we have gone into some detailed evaluation about a child with epilepsy and how to approach a child with epilepsy, and then how to manage status epilepticus. And in summary, all children with convulsive seizures should have a 12-lead ECG. Full, accurate history and video recording is of utmost importance in evaluation of a child with epilepsy. Neurological examination is must. EEG is needed. Classify, and MRI is sometimes important, especially if it's a focal epilepsy or a resistant one. Sleep deprived or medication induced EEG increases the diagnostic yield, and specific indications are there for functional neuroimaging, genetic, and metabolic screen. Okay, I think we have come into the end of the lecture. Thank you.